rheumatic heart disease আজ rheumatic heart disease থেকে তার মেনলি কমপ্লিকেশনস অর্থাৎ rheumatic valvular disease known as rheumatic heart disease valvular disease বলতে গিয়ে আমার মাথায় রাখতে হবে mitral valve aortic valve and the semilunar valves valvular heart disease may involve mitral valve, aortic valve, and least commonly tricuspid valve, and virtually involvement of the pulmonic valve is the secondary involvement. That means as a consequence of the either mitral or aortic valve abnormalities. Now coming to the point of anatomic structure of the mitral valve. Now the mitral valve component, virtually mitral valve is a three-dimensional anatomic structure having 5 components. Number 1, annulus. Number 2, anterior and posterior leaflets. Number 3, chordae tendineae. Number 4, papillary muscles. In addition to those, there are also other 2 components like annulus and the commissures. So, the mitral valve apparatus is a 3-dimensional anatomic structure having number 1, annulus, number 2, commissures, number 3, chordae tendineae, number 4, papillary muscles, number 5, subjacent myocardium. Abnormality in any one may result in the mitral valve disease. Mitral valve disease কে আমরা 3টে ক্যাটাগরি বা সাব ক্যাটাগরিতে ডিসকাস করব। Number 1, mitral stenosis, number 2, mitral regurgitation, and a very rare disease, that is the mitral valve prolapse. Now coming to the point of genesis of valvular heart disease in the setting of rheumatic fever. Initial episode of acute rheumatic carditis. তার দুটো কনসিকুয়েন্স থাকতে পারে, একটা হচ্ছে fulminant or severe degree of inflammation. সেখানে আবার আমরা দুটো ভাগে সাব ক্যাটাগরাইজ করতে পারি। One is severe caudal and mitral leaflet inflammation. সুতরাং inflammation of the tendinous chordae as well as mitral valve leaflet that is severe or fulminant in its nature usually produce acute severe mitral regurgitation. The second one, that is the moderate active caudal and mitral leaflet inflammation, that when confronted by repeated episodes of acute rheumatic carditis produces caudal and mitral leaflet thickening, fibrosis, retraction, and commissural fusion. The result is a pathophysiological lesion is mixed mitral stenosis and mitral regurgitation. On the other hand, mild to moderate degree of inflammation, often subclinical in its nature. Again, it has got 2 fates, one complete resolution and improvement of the residual deformity, and the second one is repeated attacks or episodes of the acute rheumatic carditis that may produce chronic caudal and mitral leaflet inflammation, having 2 sequences depending on the age of the patient. With the aging process, degree of calcification increases within the mitral valve leaflet and produces mitral stenosis with calcification of the mitral valve and mitral valve leaflet immobility. Second one is the repeated episodes of acute rheumatic carditis in the younger age group produces mitral valve is pliable, that is having mobility. That means the minimal or no calcification. This is the pathogenic process involved in the genesis of the mitral valve disease, both mitral regurgitation as well as mitral stenosis. Now coming to the point of mitral stenosis. Mitral stenosis should be discussed in the light of etiology, symptoms, physical examination, severity, natural history, investigations, and definitely timing of the surgery as well as the management, if any. Now the etiologic basis, most common cause is rheumatic fever. তাছাড়া থাকতে পারে congenital, that may be a result of parachute valve or cord triatriatum. Third, severe mitral annular calcification with involvement of the mitral valve leaflet. Then systemic lupus erythematosus and rheumatoid arthritis are also responsible for the development of mitral stenosis. Then left atrial myxoma, a tumor within the left atrium producing obstruction at the level of the mitral valve with resultant mitral stenosis. And lastly, infective endocarditis with large vegetations increasing on the mitral valve leaflets and obstruction. So these are the etiologic basis of mitral stenosis. Rheumatic fever, congenital, severe mitral annular calcification, systemic lupus erythematosus, rheumatoid arthritis, myxoma, and infective endocarditis. Now, pathophysiologic basis. Normal mitral valve orifice area is 4 to 6 square centimeter. Mild mitral stenosis 1.5 to 2.5 square centimeter. Usually symptoms is minimum either at rest or on exertion. Third, moderate mitral stenosis, mitral valve orifice area 1 to 1.5 square centimeter, usually asymptomatic, but may be symptomatic on exertion or exercise. And third, the severe degree of mitral stenosis, mitral valve orifice area less than 1 square centimeter. So, on the basis of the area of orifice of mitral valve, it can be categorized mild, moderate, severe. Normal 4 to 6, mild 1.5 to 2.5, moderate 1 to 1.5, and severe less than or equal to 1 square centimeter. Now the hemodynamic consequences. Mitral stenosis means narrowing of the mitral valve, that means inadequate filling of the left ventricle. So hemodynamic consequence again can be subcategorized into altered filling dynamics or altered filling pattern, left atrial enlargement, hypertension and remodeling, and third the pulmonary hypertension, both venous hypertension as well as arterial hypertension. Again, the hemodynamic and structural sequelae or consequences of the mitral stenosis. First, alteration of the filling hemodynamics. Second, development of left atrial hypertension and remodeling. Third, development of the pulmonary venous as well as arterial hypertension. Now, this is the classical representation or graphic representation. Hemodynamic alterations mitral stenosis, LA pressure overload, pulmonary venous hypertension, pulmonary arterial hypertension, progressive pulmonary arterial hypertension, right ventricular pressure overload, right ventricular dilatation or enlargement, development of the tricuspid regurgitation. And on the other hand, from the pulmonary arterial hypertension, there is development of the pulmonary regurgitation. The structural sequelae, the left atrial enlargement and hemodynamic stasis may produce left atrial thrombus, or left atrial enlargement may produce a substrate for the genesis of the atrial fibrillation, and the left atrial dilatation may produce obstruction of the recurrent laryngeal nerve, producing a clinical symptom of hoarseness of voice. On the other hand, development of the pulmonary venous hypertension may produce rupture of the bronchopulmonary anastomosis with the resultant symptom of hemoptysis, and that is also again responsible for the genesis of the pulmonary arterial hypertension. Now, the causes of pulmonary arterial hypertension. First, passive transmission of pulmonary venous hypertension from the elevated left atrial pressure or left atrial hypertension. Second, changes in the walls of the small vessels by means of interstitial edema. Third, pulmonary arteriolar vasoconstriction in response to pulmonary venous hypertension. There is the second mitral stenosis or reactive pulmonary hypertension. And fourth, the organic obliterative changes in the pulmonary vascular bed. These four, either or in concert, may produce pulmonary arterial hypertension. Normal pulmonary arterial systolic pressure is less than 30 millimeter of mercury. So hypertension defining features hocche more than 30 millimeter of mercury. That is the pulmonary arterial pressure. So development of the pulmonary hypertension, passive transmission of the pulmonary venous pressure. Second, pulmonary arteriolar vasoconstriction in response to pulmonary venous hypertension, that is the reactive in nature. Third, the interstitial edema compressing the walls of the small vessels, that is the arterioles. And fourth, the organic obliterative changes in the pulmonary vascular bed producing pulmonary arterial hypertension. Symptoms, নতুন করে বলার কিছু নেই. Usually in the setting of stenosis, dyspnea on exertion that may progress to orthopnea, paroxysmal nocturnal dyspnea, depending on the progression of the disease. Exercise intolerance or easy fatigability, or palpitation in case of genesis or development of arrhythmia, especially atrial fibrillation. And left-sided heart failure, producing the features of so-called heart failure like orthopnea, paroxysmal nocturnal dyspnea, or changes in the jugular venous pulsation. And atrial fibrillation, systemic embolization, repeated pulmonary infection, hemoptysis, right-sided heart failure, and worsened by conditions that may increase the cardiac output, such as increase in heart rate or development of arrhythmia or pregnancy or thyrotoxicosis. These are the symptomatology resulting from mitral stenosis. Now, palpation, small pulse, small low volume pulse, number 1. Number 2, BP is usually normal or subnormal. Number 3, jugular venous pressure, there may be prominent A wave and delayed Y descent because of the delayed filling or slow free of the left ventricle. Then comes the apex beat. Palpable S1 may be present. There may be a thrill that is diastolic in its nature. Third point, there may be on occasion palpable opening snap. Left parasternal, left reflecting right ventricular hypertrophy. Now the ECG findings. Now we have auscultation. S1 apex beat is tapping in its nature, usually normal in its location or slightly outside the mid-clavicular line due to right ventricular enlargement. Second, the S1 is short, sharp, accentuated. Short, sharp, accentuated in a setting of pliable mitral valve. By setting of sclerosed mitral valve, the S1 may be diminished in its intensity. S2 is usually normal, but in the presence of pulmonary arterial hypertension, S2 is loud due to the loud pulmonic component of the secondary sound. Third, an opening snap, that is a diastolic sound immediately after the S2, more precisely 0.05 to 0.12 second after the secondary sound, that is the S2. Here, the opening snap is crucial for assessment of severity of mitral stenosis. The interval between the S2 and the opening snap is inversely proportional to the severity of the mitral stenosis. And lastly, there is the diastolic rumbling murmur. Diastolic rumbling murmur best heard in left lateral decubitus, left lateral supine recumbency. So, diastolic rumbling murmur best heard in the left lateral supine recumbency. This is the classical features of the mitral stenosis on exam. In addition to that, development of complications or the progressive mitral stenosis, additional auscultatory findings. Number one, murmur of tricuspid regurgitation, that is the pan-systolic murmur around the left parasternal border. Second, the mitral of the murmur of pulmonary arterial hypertension, that is the ground still murmur, a high-pitched blowing diastolic decrescendo murmur best heard at the right base or along the left parasternal border. These are the associated or accessory auscultatory findings of the mitral stenosis. So, S1 short, sharp, accentuated, S2 normal in intensity, but in case of pulmonary arterial hypertension, S2 is loud due to accentuated P2 component. Second, opening snap. Third, the mid-diastolic rumbling murmur. Fourth, additional features like murmur of the tricuspid regurgitation or murmur of the pulmonary regurgitation, known as ground still murmur. Natural history. Mitral valve disease, particularly mitral stenosis, is progressive and lifelong disease. Second, usually slow and stable in the initial years. Slow and stable in the initial years, and progressive acceleration in the later life or the older age group. Usually 20 to 40 years latency may be present between the initiation of the rheumatic fever and the development of mitral stenosis, and the additional 10 years before disabling symptoms. Now complications, atrial dysrhythmias, especially atrial fibrillation. তাছাড়া premature atrial contraction or supraventricular contractions may be present, or supraventricular tachyarrhythmia. Second, congestive heart failure. Third, systemic embolization. Fourth, pulmonary infarct. Fifth, repeated pulmonary infections, especially in the winter months. Then hemoptysis, usually ruptured bronchopulmonary anastomosis. And third, infective endocarditis. This is rare unless or until complicated by mitral regurgitation. And lastly, already told, repeated pulmonary infections, especially in the winter months. ECG features. First, left atrial enlargement. Second, right ventricular hypertrophy. Third, premature contractions. Fourth, atrial fibrillation and or flutter, or a combination of these. Now, left atrial enlargement. The criteria of left atrial enlargement. 1. Duration of wave in lead 2 equal to or more than 0.12 seconds. Number 2. Bi-peak P in the lead 2 with the bi-peak interval exceeding 0.04 second. Number 3. Increased terminal negativity of P wave in V1 exceeding 0.04, or Morris's index. That means the product of duration and negativity of P wave in the V1 exceeding 0.04. This is the Morris index. Third, P wave by PR segment exceeding 1.6. All these constitute the diagnostic criteria of left atrial enlargement or abnormality. ECG findings in short: P mitral, that is the left atrial enlargement, already told. Then terminal POF forces in the V1 with a negativity as well as increasing the Morris index. Then the atrial fibrillation, right axis deviation. This is the Morris's index. This is the depth of the negativity of the terminal portion of the P wave. This is the duration of the P wave. So the unit is millimeter milliseconds. Normal less than 0.04. CXR findings of the X-ray. First of all, the left atrial enlargement producing a double contour on the right side of the cardiac salute. Second, mitralization of the heart. That means straightening of the left side or left border of the heart. First, loss of normal concavity of the pulmonary vein. Second, enlargement of the left atrial appendage. These two together produce straightening of the left heart border, known as mitralization of the heart. Third, widened cranial angle. That means the angle between the two dividing bronchus is increased. Third, the pulmonary venous congestion with catheterization or redistribution of the blood flow in the upper zone contrasted to the lower zone. This is the case of pulmonary venous hypertension. But with the development of the pulmonary arterial hypertension, there is peripheral throbbing of the blood vessels with prominence of the central pulmonary arteries. The central pulmonary arteries and pruning or attenuation of the peripheral vasculature. These are the vascular changes in the X-ray chest. Now in summary, X-ray দেখতে পাচ্ছি left atrial enlargement, mitralization of the heart, second third widened carinal angle, fourth pulmonary congestion, followed by pulmonary arterial hypertension features, and then lastly the mitral valve calcification, especially in the older age group or long-standing mitral stenosis subjected to repeated hemodynamic trauma with development of the fibrosis. This is the double contour of the cardiac salute. This is the right heart border, and this is the enlargement of the left atrium. So double contour is a feature of left atrial enlargement. Nowadays is very, very rare because of improved treatment of the mitral stenosis. Then echocardiography. The first ECG, first clinical, then ECG, then X-ray, now echocardiography. কারণ কি diagnosis of mitral stenosis, number 1. Assessment of the hemodynamic severity including transmitral flow and the transvalvular gradient. Normal less than 5, mild 5 to 10, and moderate to severe, that is more than 10 millimeter of mercury. This is the transmitral valvular gradient. Assessment of the right ventricular size and function, and assessment of the valve morphology, valve mobility, and suitability for the therapeutic strategy. Now stage, this is crucial for the management of mitral stenosis. Stage A, সাধারণত স্টেজগুলো করা হয় on the basis of valve anatomy, valve hemodynamics, hemodynamic consequences, and the symptoms. Valve anatomy, valve hemodynamics, hemodynamic consequences, and the symptoms. So stage A, that is the at risk for mitral stenosis, valve anatomy, only the diastolic domain, no definite organic pathology is noted. Symptoms is nil. B, progressive mitral stenosis, that is the diastolic domain plus commissural fusion. Third, asymptomatic severe mitral stenosis, সেক্ষেত্রে diastolic domain, commissural fusion, and reduction in the valve orifice area. And third, asymptomatic severe mitral stenosis, all of these already stated plus symptoms A, B, C, D on the basis of valve anatomy, valve hemodynamics, hemodynamic consequences, and lastly the symptoms. কেন গুরুত্বপূর্ণ সেটা পরে আসছে। Now medical management. First, diuretic therapy if evidence of congestion or failure. Second, the correction of arrhythmias by means of beta blocker or non-dihydropyridine calcium channel blockers, or even the decoction. Third, anticoagulation, especially in presence of atrial fibrillation or in presence of the left atrial thrombus. Third, endocardial or endocarditis prophylaxis. Fourth, the surgical therapy. First, medical therapy. Number 1, diuretics if needed. Second, beta blocker or calcium channel antagonist. Third, anticoagulation. Fourth, endocardial prophylaxis. And lastly, the prophylaxis against the rheumatic fever. That means by means of injection, benzathine, penicillin. Endocarditis prophylaxis is dependent on the type of surgery or type of infection present in the body. And last, the specific management. এক্ষেত্রে আমরা তিনটা ভাগে ভাগ করতে পারি। নাম্বার 1 রিপেয়ার, নাম্বার 2 রিকনস্ট্রাকশন, and number 3 replacement. Repair, reconstruction, or replacement. What do you mean by repair? Repair by means of percutaneous balloon valvuloplasty. Repair means the commissurotomy. Repair means reconstruction. Reconstruction means commissurotomy. Again I repeat. Repair means by percutaneous balloon valvuloplasty. Repair, that is the valvuloplasty. Reconstruction, that is the commissurotomy. This is a surgical procedure, and ultimately a valve replacement. মনে রাখার সুবিধার জন্য রিপেয়ার, রিকনস্ট্রাকশন অ্যান্ড রিপ্লেসমেন্ট। কোথায় কি করব? Rheumatic mitral stenosis. Severe mitral stenosis, that is the valve orifice area usually less than or equal to 1.5 square centimeter. Symptomatic, that means stage G. Pliable valves, no clot or thrombus, and mitral regurgitation is usually less than grade 2. So no clot, valve mobility plus, and MR less than 2. Yes, option mitral balloon valvuloplasty, or on occasion commissurotomy. No, that means pliable valve, no clot, less than 2 mitral regurgitation, নেই। সেক্ষেত্রে সিভিয়ার সিমটমস অর্থাৎ NYH ক্লাস 3 or 4. সার্জিক্যাল ক্যান্ডিডেট, ইয়েস, কোনো অসুবিধা নেই, সরাসরি mitral valve surgery, that is the surgical mitral commissurotomy. নো, সেক্ষেত্রে চেষ্টা করা যেতে পারে valvuloplasty, যেখানে সার্জিক্যাল ক্যান্ডিডেট নয় বা সার্জিক্যাল রিস্ক থেকে যাচ্ছে। MS asymptomatic, that is the stage C. Option is pliable valve, একই জিনিস, no clot, less than 2 mitral regurgitation. সেক্ষেত্রে pulmonary arterial systolic pressure more than 50 millimeter of mercury. Go for mitral valve balloon commissurotomy or mitral valve balloon valvuloplasty. Pulmonary hypertension নেই, the new onset atrial fibrillation, সেক্ষেত্রে কিন্তু balloon valvuloplasty একটা অপশন হতে পারে। Option is 2B, that means not usually indicated but may be an option depending on the situation. And third, the progressive MS, that is the stage B. Mitral valve orifice area more than 1.5 square centimeter. Symptoms, especially exertional dyspnea and the hemodynamic stability or hemodynamically significant mitral stenosis. সেক্ষেত্রে অপশন হচ্ছে যে assessment of the valve morphology, that is the mobility, presence or absence of the thrombus, and the degree of mitral regurgitation, if any. Option is the mitral valve commissurotomy. এক্ষেত্রে option is secondary, otherwise medical management is sufficient enough. Mitral regurgitation. Again, এই স্লাইডটা ডিটেলসে বলা দরকার নেই, আগেই বলে দেওয়া হয়েছিল যে কম্পোনেন্টস অফ দ্য mitral valve, আমি সেগুলো শুধু স্কিমেটিক ডায়াগ্রামটাকে ভালো করে দেখানোর চেষ্টা করছি। দিস ইজ দ্য posterior commissure, this is the anteromedial commissures, and this is the posterior annulus, this is the papillary muscle, This is the chordae tendineae. This is the posterior leaflet, and this is the mitral capillary muscles. The 5 component. সেক্ষেত্রে থাকছে coordinated interaction of the annulus, commissures, leaflets, chordae tendineae, capillary muscles, and subjacent myocardium.